Mounjaro, Ozempic, Wegovy, you have seen the headlines. Millions of people are searching about vision loss and eye damage. I understand why you are looking this up. These headlines are generating real fear and in most cases real confusion. Not because the risk doesn't exist, it does, and I want to be honest with you about that, but because of the way it's been reported leaves out the most important part of the picture. In a moment, I'm going to tell you about how that risk is measured that changes the way that you read those headlines. I'll come back to it. First, 3 separate eye issues are being lumped together as one, and they are not. The distinction matters, and I'm going to help separate them now. I'm Mr. Dilraj Sahota, consultant ophthalmologist in the West Midlands with training from Oxford University and Moorfields Eye Hospital in London. 3 separate issues, different mechanisms, different levels of urgency. 1. Temporary blurry vision. Usually settles, usually benign, quite common. 2. Early worsening of diabetic retinopathy, relevant if you have diabetic eye disease. 3. NAION, a rare but serious eye condition. This is the one behind all the headlines. These are not the same thing. Treating them all as one is where the confusion starts. The most common eye symptom reported by people starting on GLP-1 medications is blurry vision. It's also the one that's most misunderstood. Thousands of people search Mounjaro blurry vision within weeks of starting this medication, assuming that it's damaging their eyes. In the majority of cases, it is not. GLP-1 medications work wonderfully to lower the blood sugar, and they do so often very quickly. When blood glucose drops rapidly, fluid shifts within the natural lens of the eye. This temporarily changes the lens shape, and therefore your optical prescription. Glasses that provided you with clear vision last month suddenly do not, and the vision blurs. But the lens itself is not damaged, therefore as the blood sugars normalize and stabilize, your prescription returns back to normal and it settles back, and the blurring will usually settle. If you're in the first 4 to 6 weeks of starting a new GLP-1 medication and your vision has blurred, do not update your prescription yet. If the blurring persists beyond 6 weeks, or you get sudden loss of vision or blurring in one eye, then see your optometrist immediately. And if it hasn't settled after 6 weeks, then you may still need to update your glasses prescription. This is the most common explanation for blurry vision. Issue 2 is different. It applies to people that have diabetic eye disease. If you have diabetes and you're being started on a GLP-1 medication, this is the issue that you need to understand properly. The key findings come from a major clinical trial called SUSTAIN-6. In that trial, diabetic patients on semaglutide had a 76% higher rate of diabetic eye complications compared to those on placebo. Things like bleeding at the back of the eye or needing laser treatment to stabilize the vision. 76% sounds alarming. Here is the vital information that coverage misses. This is the exact same early worsening effect that we've seen for decades for when diabetic patients are started on insulin. When blood sugar improves rapidly, whether it's from insulin or from GLP-1 or from any other effective diabetic medication, the damaged microvasculature at the back of the eye temporarily worsens. So that happens before the long-term benefits of having that lower blood sugar can take place. It's the speed of the improvement in the blood sugar that triggers it, not a toxic effect of the drug itself. I had a patient in clinic, diabetic macular edema, high HbA1c on treatment, and her doctor had rightly suggested that she start on GLP-1 medication. She had read the headlines and asked me directly, will this damage my eyes? That question deserved a thorough evidence answer, not a vague reassurance. And that patient is part of the reason I'm making this video. If you are diabetic and you're starting on a GLP-1 medication, do not stop, do not panic. But do make sure that you are attending your NHS diabetic retinopathy screening service. If you already have established diabetic eye disease, do let your ophthalmologist know that you're going to start on this medication so that the interval of the review can be modified accordingly. The drug is not inherently damaging to the retina. The vigilance is about managing the transition until the blood sugar levels stabilize. Issues 1 and 2 are manageable and they're largely understood. Issue 3 is the one that generated the headlines. That is the one that requires a more careful explanation. The condition behind most of the alarming headlines is NAION, non-arteritic anterior ischemic optic neuropathy. Eye specialists sometimes refer to it as an eye stroke, although that term is not quite precise. To understand who's at risk, you need to understand the 2-hit hypothesis. So the nerve usually takes 2 hits for it to become damaged to a point where the vision is damaged. Hit 1 is anatomical. Some people are born with an optic nerve disc that is smaller, tighter and more crowded, a tighter space with the same number of nerve fibers passing through it. Hit 2 is vascular. Blood flow to an already crowded optic disc becomes compromised, and that can be worsened by systemic risk factors such as high blood pressure, obesity, sleep apnea, poorly controlled diabetes. When a tight optic disc meets compromised blood flow, the nerve swells, and that compromises the blood flow further, and the nerve becomes damaged. That's NAION. What does NAION actually do to someone's vision? The experience is a sudden, painless loss of vision in one eye, usually described as a shadow, often on waking up, and it usually affects the inferior part of your vision. Complete loss of vision, total blindness, is very rare with this condition. In fact, if I see a patient that presents with total loss of vision in one eye, I'm thinking about another condition called giant cell arteritis, not NAION. The realistic picture with NAION is a bit more nuanced. Around half of patients that get this retain useful central vision, and around 40% will actually get some improvement over time in their vision. The thing that doesn't usually improve is the visual field loss. So if you lost the inferior part of your vision, that will not tend to come back. NAION is serious. It's not trivial, but Ozempic causes blindness doesn't give the full picture about what this condition actually does to your vision. One clinical point before I move on. If you are on a GLP-1 medication and you develop sudden blurry vision in one eye, like a shadow or a curtain or a grey cloud, that is same day eye casualty. Do not wait for a routine appointment. I said at the start that there's something about the way this risk is measured that changes the way that you read these headlines. We're nearly there. If this is useful, subscribe. More evidence-based eye care tips coming regularly. In February 2026, the UK medicines regulator, the MHRA, updated the safety information for semaglutide. So that includes Wegovy, Ozempic, and Rybelsus. The MHRA's conclusion, following a European-wide review by the European Medicines Agency, was that NAION is a very rare side effect associated with semaglutide. In regulatory language, very rare has a very specific definition. It means it can affect up to 1 in 10,000 people taking that medication. The MHRA did not say most people will get vision problems. They did not say stop the medication. They said this is a very rare side effect. And if you do experience sudden blurry vision, you must seek an urgent ophthalmic assessment. This is the regulator's conclusion after reviewing multiple large epidemiological studies, not just odd case reports. It is the most authoritative current statement available, and it's considerably more measured than the headlines. Many articles say semaglutide doubles the risk. The question you need to ask when you hear this is doubled from what? A relative risk increase tells you the ratio. It doesn't tell you the absolute numbers. Let's talk about the concrete numbers here. NAION affects around 10 in 100,000 people in the general population per year. In patients with type 2 diabetes, the background level is already higher. Those that get NAION are more likely if you've got diabetes, and that number varies between 11 and 80 per 100,000 people per year. The best available meta-analysis, which is a high level of scientific evidence, found that semaglutide is associated with a doubling of risk of NAION. The MHRA and the European regulators translate this doubling of risk into 1 additional case of NAION per 10,000 patients treated. Whenever you read that medical risk has doubled, always ask, doubled from what? This is one of the most clinically important distinctions in the whole conversation, and it's the one that most media outlets have failed to make. Mounjaro contains tirzepatide. Wegovy and Ozempic contain semaglutide. They are not identical medications. Think of them as cousins. They are from the same drug family, but not identical. The overwhelming majority of the scary headlines are based on semaglutide data. They are frequently reported as though they apply to all weight loss medications, including Mounjaro. A major pharmacovigilance study published in the British Journal of Ophthalmology this year in 2026, looking at data from around the world, analysing millions of adverse event reports globally, found a signal for semaglutide. The current evidence does not show the same signal for tirzepatide. That doesn't mean that Mounjaro carries zero risk. We don't have the same volume of data and research is ongoing. But current evidence has not demonstrated the same increased NAION association with tirzepatide as it has with semaglutide. The distinction matters, particularly for UK patients where Mounjaro prescribing is increasing. This is reassuring for Mounjaro users, but it's not a green light to ignore all vision problems. If you want to understand your personal risk profile, there are 4 factors which, in the evidence, typically show an increased risk of NAION. Older age, particularly over 50, male gender, systemic risk factors such as high blood pressure, uncontrolled diabetes, obesity, sleep apnea, and also the first hit in the 2-hit hypothesis that we talked about, which is a small, crowded, tight optic disc, which puts that disc at risk. If you have several of these risk factors and you're being started on semaglutide specifically, it makes sense to check with your prescriber whether a baseline eye examination would be a good idea. You will not get a clear protocol at this early stage of these new medications. That clarity is still being established, but you're entitled to ask. I started this video by saying that the headlines leave out the most important part of this picture. These medications, when they work, prevent heart attacks, prevent strokes, extend lives that would otherwise be shortened by cardiovascular disease or the effects of long-term elevated levels of blood sugar. The patients most at risk of the complications that we've talked about here are also the patients that stand to gain the most by using this medication. The risk is real, it's not zero, but it is small. And the decision about whether to take these medications is one for you and your doctor to discuss together with accurate information. Not a headline, accurate information, and that's what this is. One of the 2 clinical situations that prompted me to make this video was one of my patients with diabetic macular edema asking me about whether this medicine is going to damage her eyes. If you have diabetes or a friend or relative does and you want to understand the effect of diabetic retinopathy on your eye, then watch the next video which explains in detail about diabetic retinopathy.